chapter books and like papers to publish. She is awarded a gold medal by Canadian Organization of Medical Physics in 2022. Ladies and gentlemen, please welcome with me Professor Joanna Cygler. Joanna, Dr. Professor Joanna, you are free. Your time is now, and you can start when you are free. Thank you very much.
Well, Dr. Ahmed, thank you for the kind introduction. And I would also like to thank Dr. Aladdin and Iraqi Medical Physics Society for inviting me to speak today to you about the role of in vivo dosimetry for increased patient safety. Objectives of my talk are listed here on this slide. I will start with the rationale for in vivo dosimetry in radiation therapy, and will show how it can prevent treatment errors and their propagation to multiple fractions. Then I will discuss the challenges of clinical implementation of dosimetry systems and finish off with review of some in vivo dosimetry systems without going into too many details, because I understand that it was covered in some lectures before this year. So radiotherapy is a complex process consisting of multiple steps in which physicists play a very important role. And in fact, the main reason for the existence of the physicists in the radiotherapy is to make sure that the dose delivered to the patients is actually equal to the dose prescribed by physicians. And this then guarantees that we have the optimum tumor control probability and minimized treatment complications, as illustrated here on this graph. Somehow I lost my pointer. Okay. However, as in all complex processes, errors may happen at any step of that chain. And that's because to err is human. And as a wise man once observed many years ago, errors happen in all human activities, and that includes radiotherapy. So we all know that errors and those misadministrations in radiotherapy can result in underdosing of the tumor, which compromise the tumor control, or overdosing of healthy organs, which causes damage to organs at risk. From various published reports on dose misadministration, we also know that magnitude of radiotherapy errors ranges from a couple of millimeters to complete misses of the tumor sometimes, and from a few percent to lethal doses. Now, radiation therapy can be delivered either by external beam or by brachytherapy. And unlike external beam therapy, much brachytherapy is performed without the safeguards offered by record and verify systems available in external beam. This additionally increases the chance of errors in brachytherapy. The pictures on this slide, the gruesome pictures on this slide, show some examples of treatment complications. Overexposure or overdose leads to treatment complications which may be really sometimes so severe that patients may not be able to live with them. And such complications can be discovered during the treatment or immediately after, but sometimes long time after the treatment is finished. And it all depends on how fast the cells proliferate in the affected organs. Several years ago, there was a series of articles in New York Times which presented to general public some tragic consequences of dose misadministration in radiation therapy. So we are all excited about it and horrified what can happen even in the clinics in the advanced country like the United States. And about the same time, there have been a number of documents published compiling the radiation incidents that occur over the years. I personally find the most useful the ICRP 86 presentations that appeared in 2000. This report compiles about 46 accidents that occurred in external bin and categorized them in the way shown in this table. The largest number of incidents, as you can see here, falls in the category of bin calibration and treatment planning and dose calculation. And in the CRP report, it is also stated that that category called treatment setup and delivery is most likely underpopulated because there is a tendency to underreport such errors. In addition, the ICRP 86 loud and clearly concludes that adequate in vivo dosimetry would prevent most of those accidental exposures. So it would be obvious to take this advice seriously and implement in vivo dosimetry system in the clinics. But have we done it? No, clearly not, as documented in those already shown New York Times series that were published after ICRP report 86. So now I would like to talk for a few minutes about brachytherapy system, since they are more vulnerable to errors due to lack of recorded systems. So there are also a number of documents that complies errors in brachytherapy. So this safety report number 17 basically shows that about 30% of all errors that occurred in radiotherapy happened in brachytherapy treatments. So that's a pretty high incident rate, taking into account that brachytherapy is not as frequently used as external beam therapy. So there are separate reports for error prevention in high dose rate brachytherapy and for low dose rate brachytherapy for prostate cancer using permanently implanted sources. These reports are very, very useful since identifying types of errors is the first step in a comprehensive error prevention program. So now let's look at the demographics of errors encountered in brachytherapy, as shown in this pie chart on this slide. So we can see that equipment and procedure errors have pretty high incidence. However, they can be taken to a large degree by a well-managed quality assurance system. However, when you look at this pie chart, the largest chunk of errors is due to human errors. And human errors are much more difficult to deal with than the equipment errors. And they occur at various stages of the radiotherapy process, and if uncorrected, they could lead to substantial dose errors to patients. And the quality assurance, no matter how good it is, cannot completely eliminate them. It can minimize the number, but they will still be occurring. And various human errors occur during the treatment planning stage, of which the most common is the wrong catheter length entered during treatment planning for HDR. So, causes of human errors. The causes are very complex, but some of their errors can be attributed to high pressure work environment in brachytherapy, which involves frequently multitasking and interruption that may happen at many points during the procedure. This kind of work environment, combined with how the human brain works, specifically the prospective memory regions of the brain, frequently leads to the errors. So what is the prospective memory? Prospective memory involves remembering to perform an action at the appropriate point in the future. In other words, the critical issue in prospective memory is not retention of the intentions, but retrieval of those intentions at the appropriate moment. And this is really what is vulnerable to failure. Prospective memory, as I already mentioned, depends how human brain works and complexity of the work environment. And again, work in brachytherapy setting is basically very, very prone to this kind of errors. Because of that, the brachytherapy staff carry the high load for prospective memory and therefore for errors. And one way of dealing with that is eliminating or minimizing the interruptions during procedures. That reduces the number of prospective memory problems. But in some cases, the only way to prevent errors and the propagation to multiple fractions and patients, and therefore improve safety and efficiency in brachytherapy, that's my basically recurring leitmotif, is to do in vivo dosimetry. So I will illustrate it on the recent incident that actually happened in North America. And it involved HDR cervix treatments. And what happened, that the wrong catheter length, shorter than actual length used for treatments, was entered in the planning. That resulted in geographic miss of the tumor and overdose of healthy tissues. So the treatment unit, if this catheter length was longer entered in planning, the treatment unit would give interlock. Basically, the dummy source would bang at the end of the catheter and the treatment would be stopped. But with the shorter lengths, it doesn't happen. The treatment unit is unaware of that error. So what happened? About 25 patients were affected over the period of time by that error. All those patients got informed about the compromised treatment they received, and the error made a very big impact in a variety of ways. So first, impact on affected patients, their quality of life was very compromised. They worried about the failure of tumor control. They worried about the treatment complications. They had to get additional close follow-ups and additional diagnostic and pathological tests had to basically be ordered on periodic basis. And the final one is the emotional impact, the stress, the anxiety, and anger that it has happened to them. So now there was also impact on prospective patients because of this error and the investigation that followed. The brachytherapy operation was suspended till further notice. So that meant that prospective patients had to travel further to other cancer clinics to receive the treatment. That meant extra cost, time, and inconvenience for those patients. And now the impact on safety and efficiency of that cancer center. So what happened? Extra workload and related cost, close follow-ups of identified patients, additional tests. All this translates into financial issues, and suspension of the treatments till further notice meant also loss of funding for the center. And the last but not the least is the reputation that was compromised for that center. So we always analyze what are the lessons learned from such incidents. So there are many lessons learned, but in the context of this lecture, I would say that routine, adequate in vivo dosimetry is the most important lesson because it would limit the number of patients and treatment fractions affected by this error. The error would be detected during the first fraction treatment for the first patient. So in vivo dosimetry would improve safety and efficiency in brachytherapy. Fun enough, but it's the same conclusion as almost 20 years ago, ICRP gave to the readers, that adequate in vivo dosimetry is the way to go. But now, what does adequate mean? You know, the word means different things for different people. And does it mean that we should perform measurements for every fraction once a week, or for first fraction only? So we need to define what it means adequate, what it means in terms of patient safety. For example, ESTRO basic philosophy includes routine in vivo dosimetry as an important part in quality control of radiotherapy. And also in vivo dosimetry is required by law in some European countries. However, there are many barriers to establishing routine in vivo dosimetry. So such treatments are not performed routinely, and that's also unfortunately applicable in Canada. The reasons for those barriers are cost of equipment or cost of staff. We did some survey a number of years ago of cancer clinics in Canada, and we found out that it's the physicists who mostly perform this kind of measurements. So it's expensive stuff, right? The increased treatment and staff time. Well, this wouldn't be so increased if we had a fully integrated in vivo dosimetry system with the treatment unit. And then we have profit-driven clinics, like in the United States, and simply in vivo dosimetry will not be performed unless it is reimbursed by the insurance company. And we also deal with the staff resistance. The staff doesn't want to do it because they say, oh, it's lack of documentation, protocols and procedure, lack of proper training, extra workload. And they also worry about the workload possibly changing in the treatment team. So, however, I believe that all those reasons listed here could be overcome if we had those fully integrated systems. But okay, let's say we have fully integrated systems. There are still technical issues that are real, and basically we have to be aware of them. So technical challenges for in vivo dosimetry in external beam, we have high dose gradients in IMRT, SBRT, and radiosurgery. So the precise positioning of the detector is of paramount importance for the accurate measurement. We also have low signal-to-noise ratios in low-dose regions where we measure doses to organs at risk. In brachytherapy, we also have high-dose gradients, but in addition, we also deal with short treatment distances. And in such situations, the positioning error is even more important in terms of consequences. And if we place the detector inside the tumor or body cavity, there is always a risk of infection. So what do we need for routine in vivo dosimetry program to overcome those challenges, technical challenges? So we need a robust dosimetry system, and that means small detectors with high signal-to-noise ratio, detectors that are energy and dose rate independent, detectors that are minimally intrusive to the patient and give fast and reliable real-time dose readouts. And of course, they should be affordable. There are many types of detectors available, and they can be classified into two main categories: offline or passive dosimetry detectors, such as TLDs, optically stimulated luminescence detectors, or annealing. To name most of them, there's also film, but we'll not be talking about that. And then we have online or real-time dosimetry detectors. And those are diodes, MOSFETs, plastic scintillator detectors, radioluminescence detectors, and EPITs. And since those passive detectors required some processing after the treatment is finished. Therefore, there could be delays in obtaining the information about the dose. So in my opinion, they are not as useful as the online detectors. So I will now go over all those detectors listed on the slide very shortly, very briefly. So TLDs have been with us for the longest time. They come in many shapes, and there are a variety of readers. And here is this Harshaw 5500 reader, which we have in our technique. Another luminescence-based detector is optically stimulating luminescence detector, which has been relatively recently introduced into the radiotherapy. It was used before in radiation protection. Here we have the MicroStar system, and it uses the detectors called nanodots, which are small discs made of aluminum oxide doped with carbon crystal. One could further miniaturize the already small nanodot detector, so they could possibly fit in natural body cavities, such as, for example, rectum, to measure the dose. Another type is this alanine. And there is lots of work going on in our National Research Council about this type of dosimetry. So this is a passive detector, and irradiation of aniline causes formation of stable free radicals. And concentration of these radicals is proportional to the absorbed dose and can be measured by electron paramagnetic resonance. Alanine is available also in many forms. The problem with that detector is that one needs access to EPR spectrometer to read the dose, which is not always easy for the clinics. Another problem with aniline is that it's relatively not sensitive to low doses. We see that 2-gray signal is barely above the background. And the way when the signal is measured, the amplitude of the highest line, shown here, is used as a dosimetric signal, and it is proportional to the dose. So that's aniline. So now I start with those real-time dosimetric detectors, the diode system everybody knows. Here is the diode system from PTW for brachytherapy. It can measure rectum doses. There are 5 detectors in this probe, and it can measure the dose in the bladder. We have here the probes of different diameter. Another system is the radioluminescent system, but the same crystal as for OSL dosimetry, but the OSL signal is eliminated. And it is eliminated by pre-irradiation of such crystals to maximize the sensitivity of radioluminescence, because in pre-radiation to a high enough dose that all traps are filled, then when you use it on patient to basically measure the dose, it measures the dose rate because it measures the recombination during the treatment delivery. That's a very nice system, and the whole idea was actually started in Denmark by Klaus Andersen group. They done lots of work on that, and they developed a very nice system that actually has 2 modes of operation. One mode based on radioluminescence measures the dose rate, and the other mode measured on the based on OSL principle measures the total dose after the treatment. The detectors are coupled to the fiber optic system, and it's all computerized and really very elegant solution. I was lucky to actually use this detector in our clinic. So this slide shows the example of how they use this system for pulse dose rate brachytherapy treatments. So we see the radioluminescent signal that was integrated over the pulse in those small red dots. The open circles are the OSL signal that was measured after each pulse. And we see that they actually agree very well with treatment planning calculations within the very, within plus minus 1 millimeter uncertainty. So that's very encouraging detector and system. We also have a commercial radioluminescence system based on gallium nitride crystal, and this miniature crystal can also fit in brachytherapy needles. Next, we have plastic scintillator detectors, and there have been a plethora of such detectors developed in recent years. And on this slide, we have an example of a commercial system that can be used for both external beam and brachytherapy treatments. Scintillation signal is produced in a plastic fiber and detected by the photodiode. Here is the example of special devices made for measurements of the rectal doses with these plastic scintillator detectors. Now I would like to talk a little bit about MOSFET, which is the real-time dosimetry system as well. The MOSFETs come with two standard sizes. Micro MOSFETs is particularly useful for brachytherapy. This mobile MOSFET was developed actually in Ottawa, and I was involved in development and early evaluation of the system. The detector also comes with two active volumes, standard and the high sensitivity, and this is defined by the thickness of the oxide layer. Another system, we also have RATPOS system that we also developed in Ottawa. It is a time-resolved dosimetry system. It uses micro MOSFET as a dosimeter and electromagnetic positioning sensor combined in the same probe with the MOSFET. So the whole probe is MOSFET for dose and electromagnetic sensor for position. And this way we can measure simultaneously dose and spatial position of the probe. Here is the schematic of the system, and here it is a photo of how the RATPOS probe looks like. So it's very, very small. For comparison, you see 1 cent Canadian coin. This slide illustrates how the RATPOS can do this real-time position measurements. Here is the interface that we use to do those measurements. We developed special deformable phantom, and inside the phantom is a tumor, and the RATPOS detector can be put inside the tumor or outside the tumor in various locations. And we receive the information in 3 dimensions instantaneously or as a composite R displacement. We use this detector in phantom or in patients in external beam, but also in brachytherapy. And on the next slide, I will show you some of those measurements. So in LDR prostate brachytherapy, we use a modified RATPOS detector to measure dose and prostate deformation caused by the insertion and then removal of transrectal ultrasound probe. So in this modified probe, we actually used 5 MOSFET detectors, the array, instead of a single detector. And we placed it in the urinary catheter, and that went into the bladder. And here at this point, if you can see, there is a special radio-opaque marker that indicates the end of the RATPOS probe. And I will show you some results of the measurements now. So the coordinates of the rat pulse were read every half a second throughout the entire procedure. So for an hour or hour and a half, because it included treatment planning and seed implantation. And I want to draw your attention first to this graph. So here is the position read by rat pulse in the X direction, Y direction, and Z direction. And this is with the ultrasound probe inside the rectum. At this point, the probe was removed and the measurement continued. So we see that it is not the same values as before, as with the probe, but quite changed values are now in the position. And the biggest change occurred in the Y direction or superior inferior direction. So in this direction, the prostate deformation is the largest as a result of having ultrasound probe inside the rectum. So those are results for one patient, but we did it for a sample of 10 patients, and we see that in all cases, it was the same result. It is the average information for all patients here, that also the displacement was the largest in the Y direction. This has impact on the seed distribution inside the gland, and therefore on dose distribution. So it is important to know, because frequently we see when we do post-implant calculations that the dose is lower than was prescribed and actually calculated with the ultrasound probe still in. This brings me to the end of the discussion of standalone in vivo systems. And now I would like to tell you about two integrated systems. So for brachytherapy, we have a commercial system integrated with the treatment unit. This HDR unit is called Saginova and has a diode-based in vivo dosimetry system that is integrated with the afterloader. The system provides instantaneous readout of those measurements and indicates the errors in the report, like here in red. So one can do the corrective action during the treatment or immediately after, before the next fraction. So one can only hope that all vendors would follow the lead of this company and integrated some in vivo dosimetry system with their afterloaders. The last system I briefly mentioned is the EPIT system. And this is the system for external treatments, external beam treatments, and it is integrated with the LINAC. And EPITs were preferred modality for verification of patient positioning for external beam radiotherapy. But since EPIT also images contain also dose information, many groups has done lots of research to basically investigate the possible clinical implication for in vivo dosimetry of those measurements. And especially with the introduction of the amorphous silicone devices, shown here in the schematically in the right corner, the interest in EPIT-based dosimetry has been accelerated because amorphous silicone allows for fast dose acquisition, high resolution digital format, and basically reconstruction of the in vivo measurements and 3D dose verification. And the leader in this development has been the National Cancer Institute in the Netherlands. And they basically developed new software and clinically introduced it to allow automated image acquisition and periodically inspect the record and verify database and to automatically run the dosimetry software. And Ben Meinier, whom probably many of you know, has been a big advocate for in vivo dosimetry during his career. And he was instrumental in clinical implementation of this EPID-based dosimetry system. So this slide lists the capability of their system. So this new software that they developed allows for fully automated image acquisition. It allows for periodically inspect the record and verified database and to automatically run the EPID dosimetry software. The comparison of the EPID reconstructed and planned dose distributions is done offline, but it is available just a few minutes after the treatment. And then alerts are raised without any human intervention when deviations in the delivered dose exceed the clinical criteria, and corrective actions are scheduled for that. And they told me that some very serious errors have been traced by this Vivo EPID dosimetry system that otherwise would be undiscovered with pre-treatment verification. So as you see, we have a variety of detectors and systems available for in vivo dosimetry. And I really believe we should be using them to improve patient safety. And with this, I am coming to the end of my lecture. And to summarize, I hope that I convinced you that in vivo dosimetry is an important tool to assure safety in radiation treatments, and it should be complementary to the existing QA program. And it is the only way to verify that the dose actually delivered to the patient was the one that was intended. It can detect accidental over and underexposures, resulting in errors that could be undetected by the standard pre-treatment QA. And it should be always used whenever a new treatment technique is implemented. And in vivo dosimetry should be used for treatment or procedures that are performed without the safeguards of record and verify systems, like in brachytherapy. And online, in vivo dosimetry can provide instantaneous error correction, detection, and basically will allow for prevention of such errors to propagate to more patients and over multiple fractions. So in fact, with that, I really believe that it improves patient safety and also the safety in radiotherapy and efficiency in radiotherapy. And it can provide meaningful data for evaluation of treatment outcomes if done correctly. And with that, I would really like to thank you for your attention.